Good morning. Let us start looking at the basis cranii interna and mop it up with the applied anatomy at every point. Listen to it again and again, and then you will be able to remember it. The gyri and sulci of the brain impression, the frontal crest, the foramen cecum, the crista galli, the cribriform plate. Between the cribriform plate and the orbital plate of the frontal, you have the anterior and posterior ethmoidal foramen. So there's a nasociliary nerve which lies in the orbit, and through these anterior and posterior ethmoidal foramen pass the anterior and posterior ethmoidal nerve, which cross the cribriform plate and reach the nose and give its sensory supply: pain, touch, temperature, pressure. Olfactory nerve supplies the smell. So when the cribriform plate fractures, it can lead to CSF rhinorrhea. At the base of the crista galli, you see the jugum sphenoidale. And of course, if you go behind it, you have the tuberculum sali, the sella turcica, the dorsum sali, and you would remember the diaphragma sali, which has a hole, which is a membrane connecting the anterior and posterior clinoid processes, which has a hole through which the infundibulum of the pituitary passes, and you can see the pituitary fossa. So you see the anterior and the posterior clinoid process. There's a middle clinoid process also, and you have gone through the sella turcica, jugum sphenoidale, tuberculum sali, dorsum sali, diaphragmatic sali, and pituitary fossa. Then you know the optic foramen, and you have to know the optic nerve passes through it. And with the optic nerve, you know there is an optic chiasma, then there is an optic tract, which ends in the lateral geniculate body, going to the superior colliculus, then optic radiation, and into the calcarine sulcus. Lateral to the anterior clinoid process is the superior orbital fissure, which passes the third, fourth, fifth, sixth nerve, superior inferior ophthalmic veins, lacrimal branch of meningeal, and meningeal branch of the lacrimal artery. Then, amongst the foramen of the middle cranial fossa, you have foramen rotundum, passing the maxillary nerve, the anteriormost, the foramen ovale, passing the male, which is the mandibular nerve, the accessory meningeal artery, the lesser superficial petrosal nerve supplying the parotid, and an imagery vein. Then you have foramen spinosum, which passes the middle meningeal artery. Finally, you have foramen lacerum, through which the internal carotid artery enters. Then there is the trigeminal impression, on which under the trigeminal ganglion in the Meckel's cave lie the two holes, the hiatus for the greater and lesser superficial petrosal nerve. The greater superficial petrosal nerve passes out through the foramen lacerum into the Vidian canal, into the pterygopalatine fossa, into the orbit, and supplies the lacrimal gland. The lesser superficial petrosal nerve passes out through the foramen rotundum into the mandibular nerve, into the auriculotemporal nerve, and then supplies the parotid. Now, the middle meningeal artery can be approached through the pterion in an extradural hemorrhage, and the bleeding can be stopped. Trigeminal ganglion lies in the trigeminal impression in the Meckel's cave. So if you are injecting the trigeminal in trigeminal neuralgia, you can paralyze the parotid and the lacrimal gland by hitting at the lesser and greater superficial petrosal nerves. Just lateral to that, you have the tegmen tympani overlying the mastoidoid cells, which can get involved in the chronic suppurative otitis media, and the rupture leading to the temporal lobe abscess. Now we go on to the crest of the temporal bone. You see that there is a superior petrosal sinus, the petrosphenoid ligament of Guber, and the inferior petrosal sinus forms the canal of Dorella, in which the sixth abducent nerve lies actually in the sinus, and therefore it bends as it comes on top of the petrous temporal bone under the ligament of Guber, and this is the petrosphenoid notch. So if there is a supratentorial lesion, space occupying lesion, intracranial space occupying lesion, then it pushes the tentorium cerebelli down and the hindbrain down, and this nerve, abducent nerve, gets stretched at the bend of Wolf. This is called as the bend of Wolf. Then the nerve lies lateral to the abducent artery, enters through the supraorbital fissure and supplies the lateral rectus. So the lateral rectus gets paralyzed. Now if they ask you how would you test the lateral rectus in an unconscious patient, if you roll the head from left to right, the eyes tend to remain fixed, and because of the paralysis of the lateral rectus, that side eye will not be fixed. So this is called as the doll's eye movement, and that's how you test the nerve. Now the superior and the inferior petrosal sinus. The superior petrosal sinus drains the cavernous sinus. Superior petrosal sinus drains into the sigmoid sinus. The inferior petrosal sinus passes out through the jugular foramen, and with the sigmoid sinus it forms the internal jugular vein. In the cavernous sinus, besides the carotid artery and the sixth nerve, you have these four nerves which are called as otom. The oculomotor, third, trochlear, fourth, fifth A ophthalmic, and fifth B maxillary. Supposing there is a rupture of the internal carotid artery into the cavernous sinus, the pulsations of the cavernous sinus pass through the superior or inferior ophthalmic veins through the supraorbital fissure into the eye. So the eyeball starts pulsating, and this is called as pulsating exophthalmos. If you put a stethoscope on the eyeball, you may be able to hear the bruit, which is produced by the keratoco-cavernous fistula, blood passing through the keratoco-cavernous fistula. In the posterior cranial fossa, besides the canal of Dorella, the sinus containing the nerve, there is in the center a spheno-occipital suture dividing the dorsum celli into the basi-occiput and the sphenoid body. This fuses at 22 to 25 years. So if it is fused, then you know that it's an adult above 18 years. This is of medico-legal importance. Then you have the foramen magnum, which passes the meninges, the vertebral artery, the spinal accessory nerve, the medulla, the hypoglossal nerve going into the hypoglossal foramen, which you can see in this photograph. Anteriorly and posteriorly, the foramen magnum is attached by the anterior and posterior atlanto-occipital membranes. The internal occipital protuberance, which is at number 17, bears the confluence of sinuses. The straight sinus coming in the posterior part of falx cerebri, which drains the inferior sagittal sinus and the great cerebral vein of Galen, and the superior sagittal sinus, and it drains through the transverse sinus, sigmoid sinus into the internal jugular vein. So then we look at mastication. The buccinator pushes the food from the vestibule of the mouth between the teeth, that means from outside in, and the tongue supplied by the 12th nerve pushes the food from inside out. and then the teeth have to open and close. So teeth are opened by the mandible is opened by the lateral pterygoid, and it closes by the temporalis and the masseter and medial pterygoid acting together. Now, the masseter of one side and the medial pterygoid of the opposite side will pull the jaw towards the same side, and exactly opposite. So the jaw moves from side to side, causing a grinding movement while it closes. The salivary gland parotid mixes the saliva in the vestibule, and the submandibular gland and the sublingual gland in the mouth. So this finishes the act of mastication, and the nerves involved are the 5th, 7th and 12th. So look at these diagrams carefully and see which muscle acts how. Then once the bolus is formed, it must go into the esophagus. For it to go into the esophagus, the tongue must move up and back so that the food is squeezed from anterior to posterior. Then the nasopharynx must close. That means the soft palate, the tensor villi palati should tighten. The levator palati should pull it up. The superior constrictor should constrict, creating the passavants ridge so that the palate can close against the passavants ridge, and the nasopharynx closes. The third thing that happens is that the stylopharyngeus pulls the thyroid cartilage up, so the root of the epiglottis rises up, and the weight of the food causes the epiglottis to act like a trap door and shut the opening of the larynx, and starts acting like a slope or a ramp, so that the food bolus goes right into the laryngopharynx and then through the cricopharyngeal opening into the esophagus. So this in short summarizes how deglutition occurs. Then we talk of the internal acoustic meters. Now we are behind the palate, the petrous temporal bone ridge. We talk the internal acoustic meters, and you see the 7th nerve, which has wound round the nucleus of the 6th nerve, creating a facial colliculus, separating the pons and the medulla on the floor of the 4th ventricle. It gathers parasympathetic fibers from the superior salivary nucleus. It emerges on the ventral surface of the medulla and pons and enters the internal acoustic meatus. Now it hits the anterior superior angle of the medial wall of the ear and turns 90 degrees backwards, producing a genu. The parasympathetic fibers, which are also called as nervus intermedius, hit the genu and form a ganglion, which is called the geniculate ganglion. Now from inside the petrous temporal bone, 2 nerves arise, the greater and the lesser superficial petrosal nerve, and just below the trigeminal ganglion, under the trigeminal ganglion, in the trigeminal impression, there are 2 hiatus through which the greater and superficial petrosal nerve emerge. The greater superficial petrosal nerve passes through the foramen lacerum and draws some sympathetic fibers from around the internal carotid artery, and through the anterior margin of the foramen lacerum it passes into the deep petrosal canal, also called as the Vidial canal, which connects the foramen lacerum into the posterior wall of the pterygopalatine fossa. Here the fibers meet the sphenopalatine ganglion. From there the maxillary nerve has entered the pterygopalatine fossa through the foramen rotundum. So they hike on the maxillary nerve, which enters the orbit through the inferior orbital fissure and becomes the infraorbital nerve. Before it becomes the infraorbital nerve to emerge in the face, it gives the zygomaticotemporal and zygomaticofacial branch. The zygomaticotemporal branch communicates with the lacrimal nerve, and these parasympathetic fibers travel in that to the lacrimal nerve and the lacrimal gland. Therefore, the greater superficial petrosal nerve supplies the lacrimal gland. The lesser superficial petrosal passes into the foramen ovale, accompanied by the mandibular nerve, joins it, goes into its posterior division, then the auriculotemporal nerve, and supplies the parotid gland. The facial nerve motor fibers and parasympathetic fibers turn backwards from the genu, reach the postero superior angle of the medial border of the ear, turn into its posterior wall, travel downwards, and from here the cauda tympani nerve arises, passes between the malleus and the incus, pierces the squamotympanic fissure, lies near the spine of the sphenoid, and joins the lingual nerve, supplying the submandibular and the sublingual gland, as the lingual nerve goes under the tongue. Then it also carries taste fibers from the tongue to the tractus solitarius in the medulla. So that's the function of the cauda tympani. Then the facial nerve at the lower lateral angle of the posterior wall of the middle ear turns into the stylomastoid foramen and emerges out. As it emerges out behind the styloid foramen, you can see the upper picture. It gives a branch to the occipitalis muscle and the frontalis muscle. Then it gives a branch to the orbicularis oculi. Then it supplies the levator labii superioris elecnasi, so it can act on the ala of the nose. Then it supplies the orbicularis oris, the levator labii superioris, the levator anguli oris, the depressor labii inferioris, and the depressor anguli oris. Then the mentalis muscle, the buccinator, the zygomaticus major and minor, and corrugator of the eyebrows. So these are the muscles that are supplied by the facial nerve in its extracranial course. So after the seventh nerve, which passes into the internal acoustic meatus, we have the eighth nerve, the vestibulocochlear. The vestibulo supplying the semicircular canals go to the vestibular nucleus. And these semicircular canals tell the position of the head in relation to gravity and at what rate it is changing. The cochlear component supplies the inner ear and is responsible for the sound. Then there is the anterior inferior cerebellar artery which enters the internal acoustic meatus and makes a U, supplies the cochlea, makes a U-turn, comes out and supplies the inferior surface of the cerebellum. If there is a difference of 10% of flow between the right and the left side, it can lead to vertigo and vomiting and even blackout because of unilateral ischemia of the vestibular apparatus. Then there is the ductus endolymphaticus, which comes out from the semicircular canals, internal ear, and it maintains the fluid pressure in the inner ear and drains into the CSF. So as aqueous humor can't drain through the canal of Schlemm in the eye and causes glaucoma, so here if it cannot drain properly, it causes a condition called as Meniere's disease, which is characterized by vertigo and vomiting aggravated by moving. It is treated like glaucoma by carbonic anhydrase inhibitor or acetazolamide, which acts on the distal convoluted tubule of the kidney and causes reduction of pressure in the eye and the ear. That means treatment of glaucoma and Meniere's syndrome. Now there is something which damages the distal convoluted tubule because of cadmium, which was found in some near the Ouch River in Japan. So that water was contaminated with cadmium and it damaged the distal convoluted tubule of a large amount of population. So that the carbonic anhydrase was inhibited. The CO2 and H2O could not convert into H2CO3 and H ion and HCO3 ion. The H ion had to go out and sodium, potassium, calcium along with obligatory amount of water had to come in. So when this system failed, H ion increased in blood causing acidosis and there was hyponatremia, dehydration because of water deficiency, hypokalemia and hypocalcemia. Now this hypocalcemia led to severe rickets along the Ouch River, and this is called as the Ouch disease, and it was a Japanese environmental epidemic seen along the Ouch River. Then you have the posterior cranial fossa and you have the jugular foramen. Now the jugular foramen passes the inferior petrosal sinus anteriorly and the sigmoid sinus posteriorly, forming the internal jugular vein. Then it also passes the 9th, 10th and 11th nerve. The 9th nerve is the glossopharyngeal nerve and it supplies sensory and taste to the posterior 1/3 of tongue. So it feeds the nucleus of tractus solitarius and the sensory nucleus of the trigeminal ganglion, trigeminal nerve. The motor part of it winds round and supplies the stylopharyngeus, which lifts the thyroid cartilage during deglutition. The 10th nerve or the vagus nerve, primarily parasympathetic to the heart, GIT and the urinary bladder, gets some motor fibers from the dorsal motor nucleus of vagus, supplying the cricothyroid muscle of the larynx through the superior laryngeal nerve, and it thus controls the pitch of the voice. Then it has sends some sensory fibers to the mastoid region, which are called as the auricular branch of vagus. Greek rich men called Alterman used to stimulate the vagus to vomit after one meal so that they could take another meal at the same time as part of their social responsibility. So this is also called as the Alterman's nerve. The 11th nerve, accessory nerve, has a cranial and a spinal component. The cranial component draws its motor fibers from the dorsal motor nucleus of vagus and nucleus ambiguus, and it supplies the intrinsic laryngeal muscles through the recurrent laryngeal nerve. The spinal component pierces and supplies the sternomastoid, and then through the roof of the posterior triangle, it supplies the trapezius. Finally, you see the 12th nerve passing out through the hypoglossal foramen, and this supplies the tongue. The muscle names all end with glossus. So styloglossus pulls the tongue back, the hyoglossus pulls the tongue down, the genioglossus pulls the tongue forward, and the palatoglossus pulls the tongue up. The sagittal transverse and coronal intrinsic muscles roll it and turn it in various directions. So olfactory nerves, 20 on each side, carry smell, cross the cribriform plate, end in the olfactory bulb right and left, and end up in the amygdaloid body and part of the limbic system associated with taste. Loss of smell is called anosmia. The optic nerve fibers start from the retina on the temporal side of the left eyeball, seeing right, and nasal side of left eyeball, seeing right. So the right half is left temporal and right nasal. The nasal fibers cross, temporal fibers go to the same side of the optic tract so that the right field is seen by the left temporal and the right nasal nerve, but the left optic tract. Tract ends in the lateral geniculate body, from there to superior colliculus, then optic radiations, then to the calcitrine fissure. The whole tract is supplied by the internal carotid system except the posterior part which sees through the macula, and this is supplied by the posterior cerebral system through the vertebro-basilar axis. Thus, in internal carotid thrombosis, the middle cerebral artery thrombosis, macula or central vision is spared. Then you should understand about the chiasmal compression in pituitary tumors, which can lead to bitemporal field loss because of involvement of the nasal retinal fibers on both sides. Then we continue the mopping up. An Argyll-Robertson pupil is involvement of the Edinger-Westphal nucleus at the superior colliculus level of the midbrain, which is not functioning in TBs dorsalis in the third stage of syphilis. So light fails to constrict the same side pupil and opposite side pupil. So light direct and consensual is absent, but accommodation reflex, can cause the constriction of the pupil. So this is called as the Argyll-Robertson's pupil. Then there is the Hutchinson's pupil. It is an unequal pupil seen in head injury. The side with a subdural hemorrhage constricts and starts dilating. Then opposite side constricts and becomes dilated and fixed. Finally, both sides dilated means brain dead. So an unequal pupil in head injury indicates unilateral pressure. The third thing is Horner syndrome. If there is an injury of the upper limb and there is vascular insufficiency, then we go and block the stellate ganglion in the root of the first string. As you do that, the blood supply from the stellate ganglion, the sympathetic supply from the stellate ganglion goes along the internal carotid artery. And when the internal carotid artery is in the cavernous sinus, it passes to the third nerve supplying the mullus part of the levator palpebrae superioris. And when this is paralyzed, you have ptosis. Then it also supplies the orbicularis oculi, Horner's part, which pulls the eyeball forward. So when that is paralyzed, you have N-ophthalmos, opposite of X-ophthalmos. Then through the nasociliary branches, it supplies the dilator pupillae of the iris. And this causes meiosis. So these are the three eye signs. Then the two facial signs are anhidrosis. That means no sweat on the paralyzed side of the face. If you paint a starch iodine powder on the forehead and then provide some heat to the face, then because of sweating, the normal side will turn purple, whereas the affected side will remain white. Finally, there's flushing of the half of the face where the stellate ganglion has been successfully blocked. This is called as flax sign. So these are the ptosis, meiosis, N-ophthalmos, and hydrosis and flax sign are characteristics of the Horner syndrome. Then you are asked sometimes the lacrimal gland supply. So from the superior salivary nucleus to the facial nerve, through the geniculate ganglion, then the greater superficial petrosal nerve, then hiatus for the greater superficial nerve, which is under the trigeminal ganglion, then through the foramen lacerum joining with sympathetic fibers around the internal carotid artery, then the deep petrosal nerve or the Vidian canal connecting to the pterygopalatine fossa, relays in the sphenopalatine ganglion, goes into the ganglionic branches of the maxillary nerve, which is entering through the foramen rotundum, going out through the inferior orbital fissure into the orbit to the face as infraorbital nerve. So this nerve gives zygomatico-temporal and zygomatico-facial branches, and these fibers from the zygomatico-temporal pass to the lacrimal branch of the ophthalmic and supply the lacrimal gland. This you have to visualize, and you may have to remember, because there are lots and lots of objective questions that come out. Parotid supply is fiber from the geniculate ganglion of the 7th, hiatus of the lesser superficial pterygoid nerve, foramen ovale, mandibular nerve, auriculotemporal branch, and then the parotid gland. The submandibular and the sublingual gland supply are the parasympathetic fibers in the facial nerve. In the middle ear, cauda tympani, lingual branch of mandibular, and into these glands. Then you have to recollect about the the anatomy of pulsating exophthalmos, the cavernous sinus thrombosis, how infection travels from danger areas around lip and infratemporal fossa. You have to remember the doll's eye movement, the canal of Dorilla, the bend of Wolf issue. You have to remember that a bilateral subconjunctival hemorrhage, flame-shaped hemorrhage, is usually from loose areolar tissue bleeding, in contrast to unilateral hemorrhage, subconjunctival hemorrhage, which can be from orbit or within the eyeball. Then you have to remember the Alderman's nerve, the auricular or mastoid branch of the vagus nerve or the 10th nerve. Then you have to remember that there can be connections between nerves. So, Marcus gun phenomenon or the jaw wink reflex. Now here the lateral pterygoid, as it opens the jaw, the same way the LPS causes widening of the lifting up of the upper lid. Then this lateral pterygoid muscle activity can cause protrusion of tongue, genioglossus, or shrugging of the shoulder, which is trapezius. So those are the two other types of Marcus gun phenomenon. Then you see the orbit roof by the frontal nerve, the frontal bone, orbital plate of the frontal bone. Medial wall, green is the lacrimal. Then you see the ethmoid. The purple is the lacrimal. Then the green is the ethmoid. And then you see the lesser wing of sphenoid enclosing the optic foramen. Then between the greater and the lesser wing, which is the red, you see the superior orbital fissure in the lateral wall. Then the greater wing of sphenoid. Then you see the orbital plate of the zygomatic bone. Then on the inferior side, you see the maxilla. So these are the floor is formed by the maxilla and the zygomatic. Now if there is a carcinoma of the maxillary antrum or Burkitt's lymphoma or any tumor which is in the maxillary antrum, so it can cause a unilateral exophthalmos. Bilateral exophthalmos causing blindness and thyrotoxicosis can be depressed by removing the orbital plate of the frontal bone bilaterally. This is called as Navjiger's operation. Unilateral exophthalmos can be decompressed by removing the orbital surface of the zygomatic bone. So this is about the orbit. Then mastoiditis. Infection of mastoid cells in the chronic suppurative otitis media can be drained through the suprameatal triangle of McCavan, which is lying posterior-superior to the external acoustic meatus. It can track along the digastric or the sternomastoid muscle, and that is called as the Bezold's abscess. Through the tegment tympani, it can go into the middle cranial fossa, causing a temporal lobe abscess. Tumors of maxillary antrum can affect superiorly the orbit, medially the nose, below the palate, and behind the infratemporal and the pterygopalatine fossas. They can be given intracavitary radiation through the palatal enterostomy. Through the sphenoidal air sinus, radioactive yttrium can be planted to irradiate the pituitary in hormone-dependent tumors, in certain hormone-dependent tumors like carcinoma of the breast. Here is the posterior approach. First you see the atlas and the occiput joined by the posterior atlanto-occipital membrane. Now it has a notch, it has a hole in it, and you see the vertebral artery entering through the foramen transversorium of the atlas, curving around and going into this notch, and the first cervical nerve emerging from it. Now this is covered by the rectus capitis posterior minor from the spine of the atlas, posterior tubercle of the atlas, and rectus capitis posterior major from the spine of the second atlas, both going into the suboccipital region. That is the medial wall. Then from the spine of the axis to the transverse process of the atlas, you have the inferior oblique, and from the transverse process of the atlas to the suboccipital region, you have the superior oblique. So this is the suboccipital triangle. Then you have the lesser and greater occipital nerves winding around the inferior oblique and going into the region of the scalp. Now this is covered, this is roofed, this triangle is roofed by from lateral to medial, longissimus capitis, semispineless capitis, and clineus capitis. And above this you have the superior nuchal line, middle 1/3 giving rise to trapezius, and lateral 1/3 giving rise to sternomastoid, and this is the apex of the posterior triangle. So this is the posterior approach of the atlanto.